There we go. Okay, so I'd like to talk about human factors, especially in healthcare, and how, given our current COVID complex working environment that we have at the moment, it's highlighted the need to really focus on changing the way we train and the way we design in healthcare. So firstly, for those who don't know what human factors is, it's the application of scientific information, and that's both psychological and physiological, about humans to design object systems and environments for human use. Rarely do we actually see this referred to the concepts of training, but the reality of systems of use entails training. And so what I'm going to be talking about is where design and training collide, and the risks that if we don't manage it properly, of having very negative outcomes. So just a few examples of human factors. I want you to look at these three faces and identify what's wrong with one of them. So, did anyone notice the faces change? And now when I pause it, do you notice everything that's wrong now? Did you notice it before it flipped? So one of the problems we have with the way humans work in the real world is that our minds are conditioned to process information to pattern match with our expectations. And this is a key problem with design, and it's also a key problem with training. Similarly, if I move on to another example here, and I'm only going to give a couple of these just to refresh people's memory about human factors. How many people see the diagonal lines as parallel? So if I take away the cross-hatching, suddenly they're parallel. If I put the cross-hatching back, it's not. So again, it's another example of the way our brain processes information to drive expectation rather than see the world as it really is. The same applies for sound, it applies for touch. So for all our sensory systems, all our ways of assessing situations is dependent upon our prior experiences and expectations. So COVID's probably big in everyone's life at the moment, and I looked up last night the US data and updated this. So we've got in the US over 240,000 deaths occurring due to COVID. And the world is responding pretty effectively to COVID. So Australia's done an amazing job. There's a few countries that have done better than we have, but there are other countries in the world that are struggling with it because their health systems are not designed to cope with dramatic change and are not prepared to work effectively. So in Australia, each state has its different response. And if you could imagine having 50 states all with different responses, your chances of control are pretty poor. So every day we're concerned about this rate of infection and this rate of mortality. But what would happen if we had COVID every year, or the equivalent to COVID every year? Would we actually be worried about it, or would we actually start to acclimatize to it? So part of what we need to do is think about how we come up with rapid processing systems. So this is a traditional vaccine development process, a period that takes many years to come up with a vaccine. What we're seeing around the world at the moment is 11 major studies that will hopefully produce a vaccine in a fraction of this time by accelerating this process. There are potential risks associated with this, but at present, as far as we can tell, those people involved in the vaccine are doing an amazing job of processing and staying within the standards to achieve an effective vaccine. So although they're speeding up the time processes, when something goes wrong, they stop, they analyze what it is before they continue. And we've had 2 of the vaccines have stopped because of patients having levels of illness that are of concern. Now, they're now, I believe, both up and running. These levels of illness may have nothing to do with the vaccine, but we have processes for being safe around this design. And we're hoping to see come out of this within, instead of a period of years, a period of 18 months, an effective vaccine for COVID. And in fact, in some cases, we may be talking as little as 9 months to achieve that. But it's all based on having a very effective systematic approach that's evidence-based to get there. Now, if we were to think about healthcare, though, it's a little bit scary that in America, according to a 2016 study done at Johns Hopkins, over 250,000 people die a year from medical error. So that exceeds the figure for COVID at the moment. It's the third largest cause of death. And that hasn't changed since I started in healthcare, human factors and simulation in 1998. So we have a big problem. We have a problem where errors made by clinicians lead to the deaths of thousands of people around the world. Other studies quote this figure, estimate from their models as high as 440,000 people a year. So if we thought about the way we've approached COVID and been systematic about it, being prepared to go into debt to solve the problem, we could actually apply the same type of approach to reducing or eliminating this high level of mortality associated with medical error. So unlike vaccine trials, which are very, very well planned out, they have large amounts of evidence, they require multiple sites, they require deep analysis, deep planning. For healthcare, the technologies that we use, the processes that we use, and our training is very much ad hoc. So for the last 20 years, I've been heavily involved in detecting and responding to deteriorating patients. I have sat on the Queensland Paediatric Quality Council to analyse the root cause analysis after people have died during adverse events or being harmed during adverse events, and little has changed. What has changed over the last 20 years is the type of healthcare offered. Our healthcare systems have got much better. We treat patients who are much older, much frailer, for conditions that we wouldn't have been prepared to do surgery or other types of interventions 20 years ago. But underpinning this is the problem that we don't have a systematic approach to managing healthcare. So what I thought I'd do is present some examples about how technology and training can impact healthcare, but also how if we do it and design it or measure it incorrectly, we may have no impact at all. And alternatively, if we implement it poorly, we may have no impact at all. So here's an example from Jin, one of my PhD students who's done some incredible work on both laparoscopic surgery and colonoscopy on the use of 3D displays and how to measure whether they're effective and how to look for broader problems of implementation that may make them ineffective. So for those who haven't been into surgery, laparoscopic surgery, minimally invasive surgery, is now the most common form of surgery. The insertion of 3 or 4 holes, inserting a camera and implements through those small holes rather than opening up a large cavity, allows for quicker patient recovery time. Technically, if well-trained, faster surgery time, and now less complications compared to open surgery. However, there are problems. Traditionally, this has been done with 2D screens, and things such as depth perception become quite difficult when you don't have good visual orientation inside a patient. So there is been a lot of work recently with the advent of 3D technology to look at how we could implement this to improve surgical outcomes. Unfortunately, the early studies of this have demonstrated very mixed results. So Shin decided to actually have a look at how we could best understand why things work and how to implement an effective system around surgery. So given his results on effectiveness, so this is from one of his studies where he looked at laparoscopic surgery at a distance of 1 meter and 3 meters from the screen, comparing 2D with the normal traditional 2D with 3D visual displays. There was a massive difference in performance for the surgeons at the task. So precision was 6 times better at 1 meter and 3 times better at 3 meters with 3D. Completion time was faster. People reported less workload, which is very important in surgery. Workload not only limits the number of cases that can be addressed each day, it also increases error. And all these were found to be significant at a very high level of significance. So we know it can improve performance. And in fact, we did further tasks. We looked at a range of highly controlled tasks, whether it was moving pegs, navigating in space, or even suturing, to understand where the benefits were coming from. And again, in every single condition, 3D was better than their 2D counterpart. However, there were things that were observed both during this study and from his literature review that indicated that 3D has problems. And it's the fact that 3D may work very effectively for the surgeon in their particular task may not work for every surgeon and may not work for the surgical team. So if we go back to it, the surgeon's going to have the screen orientated to allow them to see an effective image. However, it's not only the surgeon that interacts with the patient. The assistant will be holding the camera in order to try and get a focus, and they will be off to the side. And the scrub nurses will be at quite an extreme angle to the screen. They need to look at the screen because they need to know what the surgeon's doing in order to predict what equipment the surgeon will need next. So we set up a study where Shin had the screen set at multiple levels. So with the eye level central, eye level at the top of the screen, eye level at the bottom. He positioned people in positions at all the different types of angles we would expect to find in the operating theatre, and examined people's experience of looking at the 3D image. And what he found was that there were areas within the image at which we had where people have the experience of crosstalk. So that's where the two images that create the 3D images start to separate and cause a distortion in what we actually see. So in the first study, the 15 participants viewed the screen from 176 different positions and reported on their experience of the ghosting, the crosstalk that occurs. And then with another group, we had 12 participants who then actually were assigned to clinically relevant positions. So this wasn't just mapping out the physical space, this was the positions that the clinicians would work in the operating theatre. And lo and behold, in some of these positions, especially at the wrong height or the wrong angle, people found that they had simulation sickness and the ghosting. So we actually then discussed with nurses working in clinical areas with 3D laparoscopic and with 3D colonoscopy, and the outcome from that is that they experience these feelings for real. So the problem is this system has been designed based on the previous system of 2D around the surgeon's needs, not the team's needs. So not only do we need to adjust and have multiple screens such that people at different positions can see what's happening, those screens need to be adjustable according to the person's viewing height. So suddenly something that seems like a simple replacement of a 2D screen for a 3D screen adds in a whole lot of complexity for the surgical team. So we actually have to start thinking about the benefits for the surgeon versus the trade-offs of those benefits for the other team members. And is it worthwhile moving to 3D? Now, a further factor to this is when you next see your clinician, okay, you next go to the GP or see a surgeon, it might be worthwhile inquiring when was the last time they had their skills tested. So it turns out that a good proportion, over 10% of people that we interacted, or surgeons we interacted with, had no depth perception. So their ability to use a 3D screen is very limited, probably not much better than a 2D. We also have no measurement for clinicians' visual skills, so whether they're colorblind. So when we build systems for people, we actually need to make the assumptions in healthcare at the moment that people will be very limited physiologically in their ability to perceive the world. If we don't, and we build systems for the person who has good auditory, good visual skills, then it's not going to work for all the clinicians working in our hospitals. So to take another example, here we have bronchoscopy. This is work that we did with the CSIRO, looking at how to develop a bronchoscopy simulator. There is a huge demand for bronchoscopy, that's increasing dramatically, but we don't have enough trained clinicians to do this. So how do we train up enough people to do bronchoscopy safely? And bronchoscopy is not the most comfortable of experiences. So people are pretty reluctant to be trained on. To do this procedure, the patient needs to be awake. The patient needs to have the ability to respond to feelings of having the camera inserted into their mouth, down the throat, into the lungs, and therefore minimal anesthetic is used in this type of procedure. So the obvious answer is build a simulator. So the simple thing tends to be when we build training is we find the people who are seen as experts at this, and we ask them what they do, and we design the simulator based around that. And this work was pretty impressive. They were able to use scans of patients to develop very good models of the lung, and then get expert consultation on what bronchoscopists did to perform a bronchoscopy. So how they position themselves, what they actually did with the scope, where they looked, how they managed it. So very much like this. So we have the bronchoscopist, the scope in the awake patient, and things like trying to maintain the scope vertical, point the scope in the direction that you want the scope to go throughout the lungs. So then we need to have a good model of the scope and a good model of the lungs. And we need to think about these two interactions. So how the hands interact with the scope, this all needs to be captured in the build of the simulation. However, when I came into this work, and it was about this stage, I suggested we actually didn't rely on the expert and what they said they did. We actually went and filmed the expert doing their task, because the experience with expertise is experts know about, can consciously tell us about 30% of what they know of their expertise. Much of their expertise is learnt and held very much at a subconscious level. So they have forgotten more about what they do than they've actually learnt. And so they do this very spontaneously, but their ability to teach exactly what they do is actually quite difficult. And in this case, when we went in there and filmed, so this is the concept of the simulation: build the model, flow, have your haptics, have your visuals. When we went into the operating theatres and actually looked at what they did, this is actually what we observed. Suddenly, it's not the doctor doing the procedure, it's the team doing the procedure. And at some points, there can be 4 hands on the scope. Yet if we train a trainee to do the procedure on the simulation without these other forces involved, it will change the way that they actually have to interact when they get into theatre. So this need to understand beyond what experts can teach us is very, very much about understanding the realities of people's current work, but also the possibilities of their future work. So in this example here, where our expert says the scope should always be vertical above the patient, the scope is being moved off to the side for the interaction with a staff member who is much shorter. And to get access, what we've done is bent the scope in order to be able to do that, to be able to insert, whether it be some type of local anesthetic or some type of tool into the scope. So suddenly the mental model that the expert has, that the doctor has, is actually inaccurate to the practice that they do. And when we design the training, we need to actually design for what they do, or redesign what they do, as long as it will actually still do the task. So a couple of other examples in bronchoscopy. They also work at the other end in colonoscopy. So we normally do the top first and the bottom. And how do you teach people colonoscopy? And so one of the clinicians, when we were studying this, one of the experts told us that he actually went into the next room and read the newspaper. And I asked him, why did he do that? And he said, well, the registrars actually perform better if he's not in the room with them. And I said, well, how do you know what they're doing? He says, well, if they haven't got the insertion within 20 minutes, I go in and take over. And he said there were no instructions that you could give to someone doing colonoscopy that would be helpful. And so we took this and we actually created a controlled trial with and without instruction. Now, we didn't use experts to give the instruction, because the other thing he pointed out was when the consultant comes into the room, people's nervousness goes up. The registrars actually perform worse when they're observed, because they know they're being observed. So in this case here, we had a trained instructor who wasn't one of the consultants, and we compared it with explicit learning and implicit learning, just doing the colonoscopy. And it turns out there is no difference. And that is because we do not have a language for force. We have language for sound, we have language for vision, but we don't have language for touch or force. So colonoscopy is a multi-dimensional problem where you can be pushing forward and the camera can be coming towards you as it goes around the colon. So it uses concepts of torque and rotation to get the scope to go where you want. So in other cases, you will pull the scope backwards to get it to go forwards as it has formed a loop or started to form a loop within the colon. So it turns out for some types of training, we actually need to understand that it's about wiggling it and jiggling it. It's about the individual learning from experience with a feedback system that actually has the impact on learning. And in this case here, you can see there is no difference between the trials with explicit versus implicit learning. Similarly, we also need to understand how learning and forgetting work. So on the same study on colonoscopy, we looked at how much people forgot between their sessions day to day. And it's quite significant. And in fact, how much they forget increases quite a bit as they become more and more skilled. So again, this leads to the issue about what do we do, for example, for rural colonoscopists who only do colonoscopies maybe 50 times a year. Given that the evidence is that you need about 500 a year to stay proficient, how do we address this forgetting curve? And the answer may be that if you're at a rural GP doing colonoscopy, you need to do a simulation before you actually do a colonoscopy on a patient. So it's just about rejogging the memory, bringing back the association between the forces, the haptic, the tactile, and the visual before you actually do your procedure on a patient. So we do know that we can use simulation. So this is results from a simulation training and looking at transfer, that we can actually get quite effective use of simulation to transfer and quite rapid training. So the other advantage of when we think about how we deal with people's human factors, so in this case, if it is wiggle it and jiggle it and learning by understanding how the forces occur through the visual feedback in a simulator where you have control and can experiment, we may find that we're better to train in simulation than actually on patients themselves. Other things that we can learn about human factors is the interaction between the limitations of the technology and the way we can visualize information. So here we have the CSIRO scope going through. Now these scopes are incredibly difficult to manage. If you've got small hands, they're almost impossible. Redesigning the scope with a thumb controller or some other method may dramatically improve people's ability to perform with it. But interestingly, we knew that there is a miss rate of polyps in patients. And there is some associations that these misses tend to be behind folds in the colon. So they're on the opposite side of the fold to where the camera has come from. So the CSIRO in their simulation were able to examine different groups of people. So here we have the top one here is the novice. The one below it is someone who is in early training. Sorry, incorrect. I've got the wrong way. Top one is the expert, early training, and the novice at the back. The dark areas we see are the areas that were never illuminated by the camera. So if there is a polyp there, you won't see it. So when we zoom in, if you have a trainee or novice doing your colonoscopy, there's a very good chance they're going to miss your polyps. So by training on people, not only do we have risks of perforation, we also have risks to the patient that they're not getting a proper colonoscopy. And it turns out that the experts that it's about 20% of the colon that's not seen, and that correlates lovely with several studies that demonstrate polyps are missed when they do them when a patient receives multiple colonoscopies from different people to see if any had been missed. So it's about the same rate. So we also know that our current colonoscopy is not as good as it could be. We just have to work out a way to get the technology to see better beyond these folds. And we also know from such work as this that our current design of training using patients as training tools means those patients are missing out on a proper colonoscopy because our trainees here very early on miss the majority of the colon, and even as intermediate, they're missing twice the amount of the colon compared to an expert. So we need to actually start to think seriously about how we roll out training for healthcare as well as how we roll out our healthcare systems. So we have actually started to see in the last 10, 15 years, people starting to collect evidence on how people learn. We know that lectures are a terrible way to teach. We know that current methods of teaching don't produce the level of expertise, but we often don't know why that is the case. So in the colonoscopy example, when we finally asked the experts about how they learned, some of them started pointing out that they used x-rays all the way through their colonoscopy. Now, we don't do that anymore. So the trainees that they're teaching never got the advantage of being able to see the images that the experts who are teaching them got, but the experts had forgotten how much that played in their ability to do the task. So one of the things that produces much better learning is about effective feedback systems. How do we get people to know whether they've done something right, and then give them the ability to measure that performance against norms, their own performance, and their prior performances, so that we can start to think differently about how we teach and build our assessment systems. So ECAPS is a program that looks at training students remotely as a web base, and it only came about as a result of workload. So the expert involved was unable to tutor every single student through this process, as they had in the past, because the class sizes were much smaller. So the concept here is, can we actually build the feedback loops for the student to do the task? And getting the students in teams, they performed a knee examination, and they did this on each other to start with. So they performed 3 roles. One was the role of the patient, one was the role of the examiner, and the other was the role of the camera person. And then they had to submit their examination for review by the expert clinicians. So traditionally, you would do this in front of an expert, and the expert would provide you feedback. In filming it, however, we're dealing with a very different situation. We're dealing with a situation where people may have multiple goes. They can choose what to submit, but they also get to think about it from different perspectives. What's it like to be the patient? That changes the way they communicate. They have to actually know the procedure in detail to be an effective camera person, because you need to get the camera to the right places to be able to capture what the examiner is doing. And finally, they have to be able to perform the knee examination. So although this was designed as a supplement for face-to-face, the actual outcomes was that they produced better trained clinicians by actually going through the process of having to video and capture it. In fact, they were significantly better. So I'm trying to remember what the score is. I think the expert scores over 60%. So these are self-directed. They've watched the video of the process. They've worked together as a team without an instructor in the room. And at least 2 of the students are reaching expert standard in performing this examination. 100% of the students improved in performance a significant amount. So again, it is about how do we construct learning that has effective measurement in it for the task that we actually want to do. And in this case, it's constructing that measurement and reducing the workload of the instructor and improving the performance of the students. So again, it's about systematically thinking about what we can do differently in healthcare. And I believe this has applications well outside of healthcare. The next thing is we talk about drug doses. So we know that, if you're on antibiotics, you need to take them at particular times and you need to complete the whole course of it. But our training, we're not very good at the concept of how much does each individual need. In fact, we tend to build training in healthcare around the available time of instructors to teach. So if you're learning CPR, you get a 2-day course. If you're doing advanced life support, it'll be a 2-day course. If you're doing basic CPR, it may be a 4-hour course. And you get signed off for completing the course, whether you're skilled or not at the task. So I want you to think, if you're in an ICU, what percentage of the staff should be at an excellent level of performance at something like CPR, given that the chance of a cardiac arrest is quite high in an ICU. And if you think it should be 100%, so do I, but the reality, when measured, it's about 17%, and there are several studies that now reinforce this. However, if we do frequent training with feedback, we can take that up to above 80% accuracy at the task. Similarly, we need to think about how we do systems. So this is an example from 2007/8, where we moved the Prince Charles Pediatric Intensive Cardiac Unit to the Mater Hospital. There were considerable warnings about the risks associated with this. They'd done a previous move within the Prince Charles where no changes in staff, no changes in communication or procedures, minimal change in equipment. However, the rooms are significantly different in layout. And the outcome was there were 3 serious events in the first week because people couldn't locate the equipment, even though they were all briefed on it and shown where it was. Plans for staff orientation didn't occur for all staff, and it caused major stress to the staff. They then took this and they moved to the Mater. And so the changes were going to be big. 100% of the surgical team was going to be different. The perfusionists, only 50% of the medical team was moving, and only 15% of the nursing staff. So Mark Hayden here was the clinical lead on this, and what we did is we actually simulated their existing procedures with the idea of capturing those and moving those across to the Mater. However, when we simulated those procedures, the nurses were very unhappy with the results. For the first time, they had measures of their actual performances. So we ran the first 3 simulations of 6 in a day. This was in a real ICU, sick patient, simulator, sick patient, simulator, sick patient, sick patient. So we were testing it with their real case load involved. And what it turned out was that many of the things they thought they did well, they did poorly. So the nurses went away, they redesigned their processes, they came back, and we re-simulated their processes until they were happy with the way they worked as teams. And we learned that there was a lot of issues around workload to the doctors. The doctors were overworked during cardiac reopenings. We have an example of here on the simulator during cardiac arrest. And what they needed was the nurses to set up equipment that traditionally would have to be set up by doctors. So we identified major safety issues, major equipment issues, and built tools that allowed for them to continually design and evaluate their processes. And the outcomes were dramatic. So the setup of Innovent setup, this is used during a cardiac arrest to help oxygenate the children. They went from a 22-minute setup within months down to below a 5-minute setup, and by the time they got to the Mater, they got to a 2.5-minute setup. The same for the pacemaker cables. So again, we need to link the system of delivery to the system of training, and we need to introduce measurements at all levels. Now, the final example I'm going to talk about is actually, if we design things correctly, we can actually remove the need for much of the training. So many patients in hospitals around the world die while being monitored because the clinicians don't recognize that the patient is deteriorating. That's often due to the fact that the forms they're using are so badly designed that the information gets swallowed up by the noise in the form. So more than, I think this was more than 10 years ago, we got involved with actually looking at these forms. So the Australian Commission of Quality and Safety in Healthcare commissioned us to have a look at the forms, and we examined the existing forms. So we got 42 from around Australia and New Zealand, had a look at their design problems, of which there were thousands of issues. In some cases, some hospitals had 3 different forms to do the same task, where the forms varied from ward to ward. And what we did is use the evidence base of what information was needed, in what order that information was needed, and how to visualize, to draw attention to where things were becoming abnormal, and where, so both individual variables and cumulative variables. And we came up with a design that for a lot of people looked far more complex. And in fact, when we asked clinicians, when we surveyed clinicians about their opinions, which forms they preferred, they certainly didn't prefer these new forms. They preferred the ones they were used to. However, their performance on those forms for both errors and response times was significantly worse than that of the well-designed forms. And in fact, these charts have now been validated clinically. We've looked at training. So even with training on other charts, such as the New South Wales or the Canberra chart here, where they believe very strongly that it was about the interaction between training and the use of their chart, staff trained on their chart without training on the ADS chart that we built here in Queensland performed significantly better with the ADS chart than they did with the chart they were trained on. So again, if we actually design systems taking into account how people process information, the visual distances between information, the methodologies that you can use to make information pop out, the use of effective scoring systems, we can actually drive behavior. And these charts have been independently shown to reduce the rate of cardiac arrest in one hospital by 45%, and in another hospital, mortality by 11%. So we've reduced training time, we've implemented an improvement in safety by considering it as an entire system. Our most recent work on this has actually looked at how people measure. So unfortunately, respiration rate and blood pressure, 2 of the most important measures, are often poorly measured by our clinicians in hospitals. And so we've just done 2 systematic reviews to identify the major causes of error in those measurements, such that clinicians can change that part of their behavior. So in conclusion, in complex socio-technical systems such as healthcare, but this applies to many other systems in the world, a failure to effectively design technologies, processes, and training based on the limitations and the affordances that people have will lead to high rates of human error. We know, and we've got examples where simulation and clinical settings can be used to optimize both the design of practices, the design of facilities, and the training to reduce patient harm. What we don't have is any type of standard processes for implementing technology processes and training in healthcare. And we need to revolutionize the way we actually do this, or every year we will lose as many people as COVID is killing this year. We will lose that many people due to human error in healthcare. So I'm going to open up to questions now. Very happy to discuss any of these or the general concept of what we can do around standards to bring human factors expertise into healthcare.
Thank you very much, Professor Watson. That was amazing talk. For the audience, if you have a question, please put your virtual hand up so I can see, and then maybe I need to unmute your microphone. So I'm watching to see if anyone has any question. In the meantime, maybe I could ask the first question. Is there any parallels you could draw between what you have just presented and other domains such as pilot training, driver's training, and other domains, counter IEEE task force, and so on?
So I think there are. I think we have done much better in control systems domains than we have in healthcare. In aviation, that's both pilots and air traffic controllers. In automation, we have. However, there are limitations. So, for example, we've just about, well, we've submitted and we'll have hopefully published this year a publication on driver safety. So Mark Horswell's the lead on that. And what we're doing there is we've recognized that hazards are predictable, but very hard to define. So traditional driver training, where we teach people to handle a vehicle really effectively, does not reduce car accidents. It improves people's skill at driving a vehicle, and they push how far they will go and the risks they will take up to their ability of driving. The only thing that improves your ability to handle accidents is your experience of accidents or near misses. So we have developed an online training program that provides equivalent to 1,000 years of driver crash experience, given that we only have a crash or about once every 10 years, and most near misses we often don't recognize. We're going to give people the equivalent to 1,000 years of experience in 3 hours. And that 3 hours must be spread over 6 weeks. So we know that there needs to be a time for you to process information, reflect, transfer to the car, and come back to that. And the effect size we're seeing on that is huge. So there are components that we're not doing in other industries that we could, and they're starting to come about because of the affordance of being able to capture real world experience rather than just build simulations for it. But I think in aviation is a really good example about how when the Boeing 380 was designed, it was an iterative process about designing the training, the cockpit around the crew, rather than building something and teaching the crew to use it. And we haven't done that in healthcare, and we really need to do that in healthcare.
It's amazing. It's amazing. Are there any questions from any of our participants today? I'm watching the list to see if there are any hands going up. Any questions? Oh yeah, Hushiyar. Hushiyar, over to you. Yes.
Yeah. Hello. Thank you very much for your perfect presentation. I really enjoyed it. Actually, I learned many new things today. I'm curious. In a part that you were mentioning about laparoscopy using the obviously robotic arm and stuff. I'm just curious. It might be really irrelevant, but I was wondering if, like in real, basically surgery, 2 or 3 people will normally collaborate along, for doing the task. How about the laparoscopy in that case? Is it going to be the same case, or normally one person is going to be in charge for doing the task?
So in laparoscopic surgery, there will be multiple people coordinating around the task. The surgeon is in charge. But if you watch experienced teams working together, there is very little verbal communication. A lot of it's made by eye contact. The camera operator is normally a surgeon themselves and will be trying to predict what the surgeon doing the procedure needs to see at the time. And if they're not, they'll get told what they need to see at the time. But the nurses are also doing other things to assist. So they'll be preparing the equipment that will be inserted into the laparoscopic. They will be selecting different equipment. They'll be passing and packing these things and accounting for them. So the other people in the team who will also be using some of this information will be the anaesthetic team. So experienced anaesthetic teams will be looking at how far the surgery has proceeded to work out when to stop delivering drugs.
And,
so there's a whole lot of things that go on that people weren't trained to do, they just learned to do in the real world. We could train people to do it. We could actually train them very early on. And instead of having 15-year training programs, we could have quite short training programs that are really efficient. But that would be actually about understanding the information and giving people that exposure with an accelerated method, much the same as what we do with the ECAPs or the hazard perception.
And you mentioned about cyber sickness or motion sickness during the training. Was that the case for only the person in charge of the operation or for whole team?
Mainly for the team members who are not at the right position to the 3D display. So in fact, nurses had been experiencing this for years, but never saying anything about it.
Wow, okay.
They have a huge loyalty to the team. So they would go home sick each day, not exactly knowing, but suspecting it had something to do with the 3D display. And the simple solution is putting on multiple 3D displays so those people at different angles can still see what's going on. So there are solutions to this problem, but it's thinking differently.
Yeah, perfect. Thank you very much for your great presentation today.
Just a solution, are there any way or any technique one can train individuals to be less, not to be prone to motion sickness? In my team, the reason I'm saying that several of my guys, they often try to make me sick. In fact, there was one yesterday, and they put me on a centrifuge, and everyone was waiting inside to throw up. I come out of the centrifuge and walk away, and smile at them, and they say, "Oh, wow, and you didn't get sick." I don't know if there is something wrong with me or whether I've done something that I don't get motion sick.
So motion sickness is only a small proportion of the population if something is set up correctly. So there are people like me who, if there's a tiny fraction of light that's incorrect, I'll get motion sickness from that. We do know from flight sickness that you can train people to manage it, and same with seasickness. So I suspect there are ways to train people to manage motion sickness. I don't know anyone working on it at the moment, and I think it will be a major breakthrough. It's one of the things that has inhibited the uptake of virtual reality and augmented reality is motion sickness. So if you have a class at a school and we know 15% of that class is going to suffer motion sickness, we can't use that tool because we can't give equal and fair training to everyone involved. So I do think it's an important thing to look at, but I'm not aware if anyone is doing anything to solve that at the moment.
Fantastic. Thank you very much. We have 1 minute left. If there aren't any other questions, we normally finish it on time. Professor Watson, thank you very much for your superb presentation. We thoroughly enjoyed it. We have recorded it, and if any individuals they want to go over, we'll make it available to all of the IEEE members. And once again, thank you very much for your great presentation.
Well, thank you very much for your invitation.
Thank you. Thank you.
Okay, bye.
Thank you.
Thank you.
Bye-bye.